Good morning, everyone. So it's the top of the hour. Anna Johnson, are you on the line?
I am, thank you.
Hey, going to go ahead and get us kicked started?
Sounds great. Well, thank you all for joining us. It looks like so far we have Terry Congleton, Michael Litschke, and Nicole Burnett on the line. Is there anyone else that's on there? I guess you can, if you can hear me but can't see those slides, you can send me an email if you're having any trouble getting to see the webinar. But hopefully everyone can see it. We may have some people joining us a little bit late. Just to thank you for coming and participating in the webinar today. And just to let you know how some of the things work, if you look next to your name on the right-hand side, you can select Mute Me if you don't want background noise coming in. And just at the end of the webinar, we'll remind you to unmute so that you can ask questions. And we'll be having Dr. Rosamond and Dr. Bushnell giving us an overview of the study and what's involved and the benefits to your hospital. So I can turn it over to Dr. Rosamond, who can start, or Dr. Bushnell, start the presentation.
Thanks, Anna. I'd like to welcome everyone, and we're actually going to go ahead and get started with our introductory webinars with the COMPASS study. And we'd like to thank everyone on the line who's joining us. We are thrilled that you're interested in participating and hope that you'll find this webinar beneficial. So our acknowledgement is that we do have funding from the Patient-Centered Outcomes Research Institute, and that they are very excited about working with us on post-acute stroke care, and that's what this is all about. So our team of investigators includes Pam Duncan, who many of you may know. She's the PI, but she's in Australia currently, and myself, and then Dr. Rosamond, who will be coming on in just a moment. And then I also want to introduce Dr. Sabina Gazelle, who, if you all decide to participate in this trial, she will be the engagement officer who is helping with organizing regional focus groups and stakeholder meetings, and she will we have a large group of investigators for our study team, and some of these are patients, some are caregivers, some are indirectly associated with stroke care, but each person has contributed tremendously to the intervention and the processes that we've been working on to try to get this trial launched. And in the bottom right-hand corner, we have several PCORI office members who are working with COMPASS, and that's Lauren Azar, Steve Clauser, Michelle Johnston-Fleece, and Carly Perry. Carly Perry is our program project officer with PCORI. So I'm just going to go through what our trial is, and I should actually spend just a minute introducing myself. I am a psychologist, and I'm director of the Wake Forest Baptist Stroke Center, and there is now a code stroke in our hospital. That's my pager going off, sorry about that. So I've had an interest in post-acute care and transitional care for some time now, and the idea for this really came about because of some of the things that we're doing at Wake Forest in terms of transitional care. And so why we think a trial of comprehensive post-acute stroke services is really important is because that stroke is one of the 4th leading causes of death in North Carolina. This is based on data from 2013. So, you know, in the U.S., stroke is the 5th leading cause of death, but that's not, in other words, 4th cause. And also, our state is very diverse, and we have a large African-American population who are at greater risk for having strokes, and in fact worse outcomes after stroke. And so African-Americans, both men and women, tend to have strokes at much younger ages than white men and women. So for example, 40% of stroke deaths in African-American men occur before the age of 65, and 24% of stroke deaths in African-American women are occurring before age 65. So you can see that very important to have an intervention that is inclusive of these disparities, and that's what our COMPASS trial is trying to do. So the reason why we think that a post-acute stroke service model is so important is because of these gaps that remain in stroke care. We do really well with acute stroke and hyperacute stroke, and then there are gaps that occur between discharge from the hospital and rehab, and then a larger gap between rehab and integration into the community. And as it turns out, patients who are discharged directly home are likely to not have any kind of post-acute stroke services. So a study from the U.S. Department of Health and Human Services in 2009 showed that 42% of stroke patients were not referred for any post-acute care. And then a more recent study published by one of our co-investigators, Janet Purvey-Vetger at Duke, showed that 65% of patients under age 65 were discharged without post-acute services. So there's a disparity here in young stroke patients, probably related to the fact that they may have insurance issues, underinsured or uninsured. And the other important thing is you all are involved with quality metrics for acute stroke care, and a lot of people have emphasized that, and it's probably made a difference in some of the acute stroke outcomes that we see. However, there are no similar performance indicators for post-acute care and these processes of care that we think are important after discharge. So there is some evidence that we're utilizing in the design of this intervention. The first piece of evidence comes from transitional care management. And there are multiple trials and different models of transitional care management. The one that we are utilizing is the one by Mary Naylor, which involves an advanced practice provider and a nurse. And so CMS was very excited about this idea of transitional care management and created reimbursement codes that actually cover all of the detailed coordination of care that occurs with complex chronic diseases. And the only disadvantage is that it really only covers the first 30 days because the emphasis is on reducing 30-day readmissions. The other type of evidence comes from early supported discharge. And so these are, it's composed of a hospital-based stroke team that includes rehabilitation providers, people who are emphasizing prevention of recurrent stroke, and support in terms of personal assistance and transportation and anything else that the patients might and caregivers might need once they go home. So this was designed to try to reduce length of stay for European and Canadian models where the stroke unit actually is the entire stay from the acute stroke setting through rehab and not just the acute care episode that we emphasize here in the U.S. So the idea is you take the patient home and you continue with the intense rehab that will get them in the home, get them functioning, and is basically you know, a very intensive model of home health that we really don't have here in the U.S. So by definition then, early supported discharge has never been implemented in the U.S., even though systematic reviews and meta-analyses have shown that early supported discharge reduces mortality, reduces long-term institutionalization, like nursing home placement, improves functional status, and in fact in Canada they showed that function improves even faster than if they're still in rehab in some cases. And then it has, you know, it's very great for patients, as patient satisfaction is high, but all without increasing caregiver burden. So this is the evidence for early supported discharge, and again, it's a European and Canadian model that is standard of care but never really implemented in the U.S. So the challenge is, how can we design an intervention within our U.S. health system that can improve care for stroke patients, whether they are getting rehab as an outpatient, whether they are getting home health, and amongst all these settings and providers, how can we include them in our intervention to improve functional status after stroke? But in addition to functional status, we have to work on stroke secondary prevention and include more education and more focus than we may already, especially post-discharge. We need to focus on stroke recovery, and we need to have a comprehensive coordination of services that will help patients once they leave the hospital. So this seems like a monumental task. And so our objective is to address the needs of stroke survivors and caregivers for optimal outcomes. And just by virtue of being funded by the Patient-Centered Outcomes Research Institute, our entire trial is patient-centered in the sense that we have stakeholders such as patients and caregivers involved in all aspects of the design of our trial, including vetting the intervention. Once we think we have it finished, we keep going back to the stroke patients and caregivers and asking them for more input. So we really do feel like this is an intervention essentially almost designed by and approved with a rubber stamp from stroke survivors and caregivers. We also are intending to connect hospitals and community providers and agencies that focus on chronic disease management and utilize those collaborations to help stroke patients. And then one of our most important deliverables will be an individualized e-care plan for each patient. And we have a fairly innovative set of assessments that we're using in order to design that e-care plan. So at this point, I'm going to turn it over to Dr. Rosamond, who's going to talk about the partnerships and collaborations that we'll be utilizing in this trial to improve stroke care. Wayne?
Thanks, Cheryl. Let me just say a few words about myself. I know most of you. My name is Wayne Rosamond, and I'm a professor in epidemiology at the University of North Carolina, Chapel Hill. And I've been the principal investigator of the North Carolina Stroke Care Collaborative since its inception back in 2002, and very excited to be a part of this project because it really builds on what we've been doing in North Carolina to improve the lives of stroke patients, for nearly 15 years. So this pragmatic trial that Cheryl has described and we'll say more about in a minute really is testing methods to improve post-acute care for stroke in North Carolina. It really builds on this history of collaboration and partnership. Now, historically, these partnerships really have addressed mostly aspects of acute care, and that's where the North Carolina Stroke Care Collaborative has come in. But we want to expand that into the post-discharge domain. So this trial really is based and designed around the collaborative that most of you are familiar with. The next slide, just to underscore sort of the historical momentum that we have, groups across the state have come together, both academic, private industry, state government, and others have come together to try to improve stroke care in North Carolina. The company is a natural progression of this successful collaboration. One of the key features of that collaboration, of course, is the formation of the North Carolina Stroke Care Collaborative, or the Stroke Care Registry. And the next slide just reminds you a little bit of the history of that project, really to try to improve stroke care in North Carolina and to reduce death and disability, and to to drive secondary prevention. Now, the collaborative was very instrumental in us getting this funding for this COMPASS study. You can see on the next slide is a picture of North Carolina where the darker shades represent metropolitan areas, with the lighter shades more rural. You can see the dots indicate locations of hospitals across the state, and also highlights those hospitals that have been participating in the collaborative. Back when we put the grant together, you all were very instrumental in writing letters of support, and we have many letters of support that we put in the grant, and I think that's one of the prime reasons why we got funded, is that we were able demonstrate a concrete, functional, and alive and thriving network of providers across the state. Our goal in Compass is to get 50 hospitals as a part of the study, and we've already, with these webinars and our conversations with you, are in the process of making that happen. One of the other nice things that we have going that really makes this pragmatic trial alive and is the variety of hospitals geographically, size-wise. As you can see in this map, the diversity across the state of people who are supporting the Compass study through the ongoing work that they have in the collaborative. Now, on the next slide, as you all well know, we've been through the collaborative, and other projects and other initiatives have been actively engaged in promoting and in creating new ways to drive quality improvement. And this slide just shows you a few of those things. The Compass study is just yet another progression of tools and approaches to improve the lives of stroke people in North Carolina. In fact, on the next slide, just you can see what has been accomplished through these quality improvement activities to date. This slide just shows you one picture of how to measure the improvement in care that has happened in North Carolina. This shows what's known as defect-free care. This is just looking at all the performance measures in acute care. For all those things that patients are eligible for, do they get the right treatment? In other words, does the right patient get the right treatment at the right time? And there's been a steady improvement in this percent of patients getting defect-free care in North Carolina. And I think being a part of the collaborative, the network, has played a role in that. So on the next slide, just the summary is that there's been a lot of progress in improving acute care in North Carolina, and you all have been working hard to do that. There's a lot of work yet to be done, however, in this post-acute phase, and in the collaborative, and your work and your dedication to the collaborative really provides a platform in the type of partnerships and networks that are needed in a pragmatic trial to really address and improve these gaps in post-acute stroke care. And I'm going to turn it over back to Cheryl to give you more details about how exactly we're going to, with your help, achieve those goals. Cheryl?
Thanks, Wayne. So I'm going to go into more detail now about the actual care model. And as Wayne had said earlier, this is a pragmatic clinical trial, and what that means is that the intervention has to be something that can be easily implemented and sustained. And so this is kind of the cornerstone of our care model as well. We're using real-world reimbursement models, real-world practitioners in practice. We're using the transitional care management codes that CMS has approved based on transitional care evidence, and we're using real partners across the continuum of care, both from the hospital all the way through to the community services. And finally, we feel that our care model is really designed to provide meaningful patient outcomes. So it's important to realize that a lot of what we're doing is creating the structure and the process for a care model, and it's a multidimensional type of intervention. And so the processes for post-acute stroke care include a 2-day phone call, so this is 2 business days after discharge. And one of the important activities is medication reconciliation, among other things that I'll go into in just a bit. There will be a 7 to 14-day comprehensive post-acute medical and functional assessment, as well as a caregiver assessment. And this is all occurring in the setting of roughly an hour-long advanced practice provider visit. And the 7 to 14-day time frame is dictated by the transitional care management codes by CMS. So that's the reason for that time frame. The other product, as I mentioned earlier, is an individualized e-care plan for each patient that's generated based on the assessments at the 7 to 14-day visit. And then we have a systematic system for referrals and communication, generation of primary care physician notes, generation of the e-care plan itself, generation of notes for the patient, etc. And then we'll be doing collaborations and workforce development for implementation of the intervention that includes secondary prevention, recovery, and improved health. And also an important aspect of this intervention is self-management. So we are really trying to get patients to and be empowered to take care of their own recovery. And then one of the most important things that we think will help with our implementation is the fact that we're doing quality performance indicators based on these processes. And we think that this will be something that if we prove that this intervention works, these could become the next quality performance indicators that many hospitals will be initiating. So if you participate in the trial, you will definitely get a jump on some of the processes for post-acute care that we think are important. The team involves two important people. One is the advanced practice provider, which could be a PA or an NP, and the other is a post-acute coordinator, which is an RN or a BSN. We think that this person would probably benefit from having a background in stroke rehab, in addition to some experience with community health. It would be, those are two attributes that would be extremely beneficial, but also someone who has an intimate knowledge of stroke care would be useful. So this person will do the 2-day follow-up phone call, provide education prior to discharge about the study and about the fact that they're going to get called, that they're going to have appointments that are going to be made with the nurse practitioner or PA and the primary care physician. They will also help identify a new PCP if the patient does not currently have one. And then they will be the ones who are going to provide some of the community referrals, especially to support groups, etc. And then they will be doing some follow-up calls at 30 and 60 days to see how the patient is doing. The nurse practitioner or PA portion of this intervention is the one who's going to be the billing provider, so they will see patients within 7 to 14 days. And again, the TCM code for high complexity needs to be seen within 7 days, and for moderate complexity within 14 days. This provider will establish this care plan that we're talking about, and the PAC, post-acute coordinator, will go over with the care plan with the patients and families prior to discharge from the clinic. So the APP will be the one to write orders, referrals to home health, for example, outpatient therapy, refer to falls prevention programs if necessary. They will also be doing a neurologic assessment, a cognitive and depression screen. They'll be ascertaining the patient's ability to manage their own medications, and also providing a really detailed secondary prevention plan, in addition to referral to community services if that comes up as one of the if it comes up on the algorithm for the assessments that will be done during that visit. So this person will also be the one who will be providing notes to the primary care physician. It's possible that the nurse practitioner or PA could be housed within a primary care physician's office, and therefore there would be there shouldn't be major issues with communication between the APP and the PCP. But in cases where they are separate, there will be providing notes and communications related to the care plan. So as I mentioned earlier, we had stroke patients and caregivers intimately involved with the design and approval of our intervention. And just to give you one example, it's a 60-year-old gentleman who was living in urban North Carolina and a very highly educated member of the business community who had a stroke, and he said after the stroke, I had new prescriptions, I couldn't dispense my medications into daily doses, but this math deficit was not recognized until he got home and he lived alone, had to take care of himself, and really struggled, was unable to cope. And his view was that a follow-up phone call has got to be the prime piece in stroke recovery that has to happen. So he felt that a phone call would have been very beneficial. And so what we've done is, not only is COMPASS an acronym, but we've made it a model, basically, by utilizing the different directions of the COMPASS for helping us develop the messaging and the focus for our intervention. So the N stands for numbers. This is Know Your Numbers, basically about the blood pressure management in particular, but also other important numbers, including hemoglobin A1C for diabetics, LDL cholesterol, as well as INR for folks who may be on warfarin. The E stands for engage, which is to basically be as active as you can, be proactive in your own recovery and rehabilitation, engage your mind, your hands, your arms, and your feet. And this is also addressing the issues of communication, aphasia, for example, depression, and cognitive problems. The S stands for support, which is to take advantage of support systems and resources. Many of these in the community may be available for stroke patients, and the stroke family and caregivers have absolutely no idea that just a mile away there is a support group or some other type of community service that can help stroke patients. So our goal with this direction of the COMPASS is to generally make sure that those patients are aware of resources that are available locally. And then the W stands for willingness. This is the willingness to work with your doctor to make sure that you take your medications, understand what medications you take, why you take them and when, and also just a willingness is kind of a related to adherence. And so what we were really trying to get at here was medication adherence, and we're finding and developing the tools that can help patients be more adherent to their stroke prevention medications and their medications in general, as well as lifestyle changes. So put together, we feel that the COMPASS also is a metaphor for finding the way forward after having a stroke. This is kind of the long road that many patients have to travel, and hopefully all together we're providing them with the roadmap with our intervention. The e-care planning is an integral part of our intervention, and what we think that this will help do is integrate health systems with our intervention. We have this comprehensive post-acute assessments for the patient's ability to manage their own care and recovery. It takes into account their preferences and their goals of care, what they think their current health state is, for example. It also follows patients across providers and settings. So it's generated at the 7 to 14-day visit, but it will go with the patient to the primary care, to the rehab providers, to the community services, and to home with the patient and caregiver. We feel that this intervention is consistent with CMS initiatives to incorporate social determinants of health, which is also very important in the sense that everything is moving towards these more holistic assessments to try to improve the health of populations. We also are contemplating the new chronic care management codes, which really does fit well with our intervention. This just began in January of 2015 and it's been a little bit slow to get underway, but some primary care practices in North Carolina are now adopting this, and so it could very well be a way of sustaining COMPASS even beyond the duration of our trial. And as I mentioned, we are going to try to test and develop our quality improvement metrics for post-acute care, and this would be fed back to you just like you get your acute stroke metrics from the North Carolina Collaborative. And our candidate measures are all about the processes that I've just described. So we want to understand what % of patients can actually be called within 2 days. Then this is required for the Transitional Care Management Code. We're also interested in the % of patients who can be seen within 7 to 14 days. And this could require some restructuring of post-acute processes in order to make it happen. But we do think that it's important in the scheme of trying to prevent 30-day readmissions and managing patients who may have some decline immediately after discharge. In addition, we want to make sure that all the eligible patients are referred to rehabilitation or community services, and so that's another denominator and numerator we'll be identifying with the post-acute metrics. So I'm going to talk a little bit now about the design, and as you know, this is the Comprehensive Post-Acute Stroke Service, or COMPASS trial, and our main goal is to determine the comparative effectiveness of COMPASS versus usual care on stroke survivor functional status at 90 days. Our secondary aims are focused on the caregiver. We're looking at the Modified Caregiver Strain Index. We're also looking at all-cause readmissions at 30 and 90 days, and then we'll be looking at mortality, healthcare utilization, including the TCM billing codes and use of rehab by linking with claims data at 1 year. So this is a very broad population that we're going to be targeting. We are only looking at patients who are discharged home from the participating hospitals. We are only looking at ischemic stroke, hemorrhagic stroke, and TIA patients who go home. Our exclusions are for patients who are discharged to a skilled nursing or inpatient rehab facility, patients who do not speak English or Spanish, or if they're under the age of 18. I should also mention that subdural hematoma and subarachnoid hemorrhage are excluded from this trial. So just ischemic and hemorrhagic stroke patients who go home, essentially. This is a cluster-randomized pragmatic trial, and what that means is that we are actually going to randomize by hospital, and we do that to try to balance groups. We're going to stratify by hospital characteristics, including the most important is probably stroke volume, so less than 100 patients per year, 100 to 299 per year, or greater than 300. And then we'll also be including primary stroke center status. So altogether we'll have 6 strata to try to balance the groups in each, to the patients in each group. Our primary outcome is the stroke impact scale at 16 at 90 days, and this is a patient-reported outcome that was actually developed by patient and caregiver focus groups. So we feel that not only is our design patient-centered, but also our outcome. The secondary outcomes are the use of the Modified Caregiver Strain Index at 90 days, as well as the all-cause readmissions and the mortality, healthcare utilization using the claims data. So here is our study design, and we start with hospitals that are eligible and interested. We will randomize half of them to receive the intervention and the other half to usual care. Our goal is 50 hospitals, so 25 to each group. And then we collect data for a year, and then at 1 year, the usual care group will transfer or will transition to the intervention, and then the initial intervention group of hospitals will attempt to sustain the intervention without any additional funds from the PCORI award. And then we will be looking at 1 year of data again, so basically 2 years of data, to see if we can sustain this intervention after the trial has ended. We do envision 6,000 patients being enrolled in year 1, and then we will assume that we might get another 3,000 that would be enrolled in year 3 that we'll be tracking. Very important to try to organize communities for this intervention, and so Sabina Gazelle will be looking at identifying coalitions of people who will be doing focus groups and helping us with our integrity of our training modules. Is it consistent with hospital operations and community settings? And then during the study, we'll have ongoing focus groups as well. One of the important things, too, is that it looks like the post-acute coordinator is going to have a major set of responsibilities in this study, and so we want to make sure that they are supported. So they're going to have biweekly calls with Sylvia Coleman, who is our post-acute coordinator manager for this trial, and so every other week there will be an opportunity to talk about problems, issues, barriers, and solutions. So there will also be quarterly calls with the PACs and the engagement committee, which will be run by Sabina Gazelle. So a lot of interaction. We think that our training will be very detailed. We'll have regional workshops and piggyback on other events that are already scheduled. We'll be scheduling focus groups with the hospitals, as mentioned on the previous slide. We'll have hospital surveys to figure out where everybody is at the time of this intervention. A lot of hospitals have asked us, or personnel have asked us, well, do we have to change what we're doing now? And our answer is absolutely not. If you have initiatives in place, keep doing them. Our goal is to see if the really intensive coordinated care with COMPASS can improve outcomes above and beyond usual care. We'll also be doing workforce development for sustainable and collaborative management with all of the providers post-discharge, including home health agencies, outpatient therapy settings, as well as community agencies. And so all of this together is basically to show you what our goals are, our aims in terms of the comparison of groups, and the care model itself and how that might improve post-acute care. And now I'm going to turn it over to Wayne, who's going to talk about the hospital recruitment. Wayne?
Thanks, Cheryl. Yes, so I would like to talk a little bit about how you may get involved in this project and what resources we can bring and what kind of what is the scope of things that we'd be asking you to perform. So first of all, as Cheryl has said, we have a lot of resources, a lot of expertise that we can help support hospitals who want to be a part of this COMPASS effort. We have funds in the grant to support on a per case enrollment basis funds that would help offset the salary for the post-acute care coordinator and also pay for training to understand the different aspects of COMPASS and how to actually implement the intervention. I'll say a little bit more about that per case enrollment schedule in a moment. We also will help train the other folks involved, advanced practice practitioner to help perform the post-acute comprehensive assessments. We'll have training for billing of the TCM coding and the other new advances in this reimbursement scheme that are new. These new rules will help you understand those so you can apply those appropriately. And as Cheryl mentioned earlier on one of our very first slides about the number of people that are involved in this project. So we have a lot of personal resources with expertise in different areas that are at your disposal to help you carry this out. We also will be building with you these community coalitions, and will help you build that structure with expertise from people on the team. Now, next slide also shows that the end game is to help patients live better lives, as I said before, and so there are benefits to the patient, your patients, if you were to be a part of this study. And of course, we're trying to improve functional status and patient outcomes, things that matter to patients. We're trying to address patient satisfaction with care and ultimately reduce readmission rates that have become more and more important in the whole area of stroke and care reimbursement plans. Cheryl mentioned this e-care planning, this new care plan that will accompany patients across various post-acute providers is really cutting edge, and to be a part of this helps allow your patients really get the most advanced post-care structure and framework possible. Now, there, of course, are all other benefits to your system in your hospital that I have on the next slide. You know, we're all trying to prepare for and understand population health management and the facilitation of systems to implement the CMS coding and payment schedules. We're all trying to understand that. I think being a part of Compass brings a lot of resources to help you prepare for that. We, as I mentioned, have grant support for the post-acute care coordinator for the duration of the intervention, and this systematic framework of coordination, integration with the community, community engagement, connection of different services once someone goes home is all part of the global continuum of care QI effort, and being a part of Compass, I think, really puts you in the forefront of making those things all fit together. I want to mention again about the financial support that we will bring, which is just one part of the resources that we have. Hospitals that are randomized to intervention in the first phase will get $50 per case enrolled, $14,000 to help train their staff on the intervention components that Cheryl has mentioned, an additional $105 per case to help offset because the post-acute care coordinator's efforts in the two-day call, and we'll also help you with the TCM billing method, which will bring resources to bear if you're involved in the intervention. The usual care hospitals in phase one will get $50 just to enroll a case, and once they are transitioned to intervention in phase two, they will receive the reimbursements that are noted above for intervention hospitals. So to give you an idea of what kind of dollars these mean, I've just sort of put together sort of a predicted median reimbursement idea. So depending on your annual stroke volume and whether you're on intervention or usual care, so let's just think about the first phase. If you're in 100 to 300 bed, 100 or 300 strokes per year, you would get over $31,000 from Compass on a per case basis, plus an additional $28,000 for the billing revenue, for a total of about $60,000. In the usual care phase, there would just be enrolling patients, entering them in a database, you would be receiving just under $6,000. And then when you're switched to the intervention, you would receive based on that schedule. So this gives you a little idea of where you're at and an estimate based on some assumptions about the number of patients that are actually eligible, which of course are those who are discharged home that'll be eligible for Compass. So let me just move past the dollar and talk where we are. This webinar is part of our recruitment phase. What would happen next, of course, would be we would follow up with you about details of your involvement, exactly what is the scope of work you'd be signing on for, a letter of agreement that we would engage with you, and we would be happy to answer any questions or come visit you or talk to your staff either in person or also on a conference call to help answer questions that your hospital might have. So we are actively in that phase. So the next slide, I just want to quickly summarize, and I want to make sure there's time for the answer to the questions you might have, is that we've done, with your help and your commitment, have done a tremendous amount of work and progress in improving acute stroke care as measured by defect-free care is just one metric in North Carolina. although there's a tremendous variability in stroke discharge planning process, and there's gaps in what happens after a patient goes home that Cheryl has alluded to. We're now at an opportunity to take the investment that we have all made in North Carolina and expand that success that we've had in the acute care domain and move that to another area that needs a lot of attention, which is this chronic management. What happens when someone goes home and tries to regain their life? And I think this is a great opportunity to be really on the forefront of a coordinated effort to try to make a difference in that area. So let me just go to the next slide and just say that together we can make this happen, to continue the success story in North Carolina to addressing stroke care. And let me just end there. Have a slide that shows you how to connect to our website. But I think now would be a great and efficient time to open things up and address any specific questions or clarifications that we can provide at this point as we try to engage with you to be a part of this cutting-edge trial.
So this is Anna Johnson, and if you have your name on mute, if you could just unmute yourself, and if you have any questions, please go ahead.